Kidney and urinary tract pathology. Congenital. Horseshoe kidney. Conjoined kidneys are usually connected at the lower pole. This is the most common congenital renal anomaly. The kidney is abnormally located in the lower abdomen. A horseshoe kidney gets caught on the inferior mesenteric artery route during its ascent from the pelvis to the abdomen. Renal agenesis. This is absent kidney formation and may be unilateral or bilateral. Unilateral agenesis leads to hypertrophy of the existing kidney. Hyperfiltration increases the risk of renal failure later in life. Bilateral agenesis leads to oligohydramnios with lung hypoplasia, flat face with low-set ears, and developmental defects of the extremities, known as Potter's sequence. It is incompatible with life. Dysplastic kidney. This is a non-inherited, congenital malformation of the renal parenchyma characterized by cysts and abnormal tissue, such as cartilage. It is usually unilateral. When bilateral, it must be distinguished from inherited polycystic kidney disease. Polycystic kidney disease. This is an inherited defect leading to bilateral enlarged kidneys with cysts in the renal cortex and medulla. The autosomal recessive form presents in infants as worsening renal failure and hypertension. Newborns may present with Potter sequence. It is associated with congenital hepatic fibrosis, which leads to portal hypertension and hepatic cysts. The autosomal dominant form presents in young adults as hypertension due to increased renin, hematuria, and worsening renal failure. It is due to a mutation in the APKD1 or APKD2 gene. Cysts develop over time. It is associated with Barry aneurysm, hepatic cysts, and mitral valve prolapse. Medullary cystic kidney disease. This is an inherited autosomal dominant defect, leading to cysts in the medullary collecting ducts. Parenchymal fibrosis results in shrunken kidneys and worsening renal failure. Acute renal failure. Basic principles. Acute, severe decrease in renal function develops within days. The hallmark is azotemia, which is an increased blood, urea nitrogen, and creatinine, often with oliguria. It is divided into prerenal, postrenal, and intrarenal azotemia based on etiology. Prerenal azotemia. This is due to decreased blood flow to the kidneys, for example in cardiac failure, and is a common cause of acute renal failure. Decreased blood flow results in a decreased glomerular filtration rate, azotemia, and oliguria. Reabsorption of fluid and blood urea nitrogen ensues, leading to a serum blood urea nitrogen to creatinine ratio greater than 15. Tubular function remains intact, resulting in a fractional excretion of sodium of less than 1% and urine osmolality greater than 500 milliosmoles per kilogram. Postrenal azotemia. This is due to obstruction of the urinary tract downstream from the kidney, for example, in the ureters. Decreased outflow results in a decreased glomerular filtration rate, azotemia, and oliguria. During the early stage of obstruction, increased tubular pressure forces blood urea nitrogen into the blood, leading to a serum blood urea nitrogen to creatinine ratio greater than 15. Tubular function remains intact, with a fractional excretion of sodium of less than 1% and urine osmolality greater than 500 milliosmoles per kilogram. With long-standing obstruction, tubular damage ensues, resulting in decreased reabsorption of blood urea nitrogen, seen as a serum blood urea nitrogen to creatinine ratio of less than 15. Decreased reabsorption of sodium with a fractional excretion of sodium of greater than 2% and an inability to concentrate urine, with urine osmolality less than 500 milliosmoles per kilogram. Acute tubular necrosis. This involves injury and necrosis of tubular epithelial cells and is the most common cause of acute renal failure, specifically intrarenal azotemia. Necrotic cells plug the tubules. This obstruction decreases the glomerular filtration rate. Brown, granular casts are seen in the urine. Dysfunctional tubular epithelium results in decreased reabsorption of blood urea nitrogen, seen as a serum blood urea nitrogen to creatinine ratio of less than 15. Decreased reabsorption of sodium with a fractional excretion of sodium of greater than 2%, and an inability to concentrate urine, with urine osmolality less than 500 milliosmoles per kilogram. The etiology may be ischemic or nephrotoxic. Ischemia from a decreased blood supply results in necrosis of tubules. This is often preceded by prerenal azotemia. The proximal tubule and medullary segment of the thick ascending limb are particularly susceptible to ischemic damage. A nephrotoxic cause involves toxic agents that result in necrosis of tubules. The proximal tubule is particularly susceptible. Causes include aminoglycosides, which are the most common, heavy metals like lead, myoglobinuria from a crush injury to muscle, ethylene glycol, which is associated with oxalate crystals in urine, radiocontrast dye, and urate as seen in tumor lysis syndrome. Hydration and allopurinol are used prior to initiation of chemotherapy to decrease the risk of urate-induced acute tubular necrosis. Clinical features include oliguria with brown, granular casts, elevated blood urea nitrogen and creatinine, and hyperkalemia due to decreased renal excretion with metabolic acidosis. It is reversible, but often requires supportive dialysis since electrolyte imbalances can be fatal. Oliguria can persist for 2 to 3 weeks before recovery because tubular cells, which are stable cells, take time to re-enter the cell cycle and regenerate. Acute interstitial nephritis. This is a drug-induced hypersensitivity involving the interstitium and tubules and results in acute renal failure, or intrarenal azotemia. Causes include nonsteroidal anti-inflammatory drugs, penicillin, and diuretics. It presents as oliguria, fever, and rash days to weeks after starting a drug. Eosinophils may be seen in the urine. It resolves with cessation of the drug. It may progress to renal papillary necrosis. Renal papillary necrosis. This is necrosis of the renal papillae. It presents with gross hematuria and flank pain. Causes include chronic analgesic abuse, for example with long-term phenacetin or aspirin use, diabetes mellitus, sickle cell trait or disease, and severe acute pyelonephritis. Nephrotic syndrome. Basic principles. Glomerular disorders are characterized by proteinuria greater than 3.5 grams per day, resulting in hypoalbuminemia, causing pitting edema. Hypogammaglobulinemia, leading to an increased risk of infection. A hypercoagulable state due to the loss of antithrombin 3, and hyperlipidemia and hypercholesterolemia, which may result in fatty casts in the urine. Minimal change disease. This is the most common cause of nephrotic syndrome in children. It is usually idiopathic, but may be associated with Hodgkin lymphoma. Glomeruli appear normal on hematoxylin and eosin stain. Lipid may be seen in proximal tubule cells. There is effacement of foot processes on electron microscopy. There are no immune complex deposits, resulting in negative immunofluorescence. It presents with selective proteinuria, meaning loss of albumin, but not immunoglobulin. It shows an excellent response to steroids, as the damage is mediated by cytokines from T cells. Focal segmental glomerulosclerosis. This is the most common cause of nephrotic syndrome in Hispanics and African Americans. It is usually idiopathic, but may be associated with HIV, heroin use, and sickle cell disease. It shows focal and segmental sclerosis on hematoxylin and eosin stain, meaning some glomeruli are affected and only part of the glomerulus is involved. There is effacement of foot processes on electron microscopy. There are no immune complex deposits, resulting in negative immunofluorescence. It shows a poor response to steroids and progresses to chronic renal failure. Membranous nephropathy. This is the most common cause of nephrotic syndrome in Caucasian adults. It is usually idiopathic, but may be associated with hepatitis B or C, solid tumors, systemic lupus erythematosus, or drugs like nonsteroidal anti-inflammatory drugs and penicillamine. There is a thick glomerular basement membrane on hematoxylin and eosin stain. It is due to immune complex deposition, showing granular immunofluorescence, with subepithelial deposits having a spike and dome appearance on electron microscopy. It shows a poor response to steroids and progresses to chronic renal failure. MEMBRANOPROLIFERATIVE glomerulonephritis. This shows a thick glomerular basement membrane on hematoxylin and eosin stain, often with a tram-track appearance. It is due to immune complex deposition, showing granular immunofluorescence. It is divided into two types based on the location of deposits. Type 1 has subendothelial deposits and is associated with hepatitis B virus and hepatitis E virus. Type 2, dense deposit disease, has intramembranous deposits and is associated with C3 nephritic factor, an autoantibody that stabilizes C3 convertase, leading to overactivation of complement, inflammation, and low levels of circulating C3. It shows a poor response to steroids and progresses to chronic renal failure. Diabetes mellitus. High serum glucose leads to non-enzymatic glycosylation of the vascular basement membrane, resulting in hyaline arteriolosclerosis. The glomerular efferent arteriole is more affected than the afferent arteriole, leading to high glomerular filtration pressure. Hyperfiltration injury leads to microalbuminuria. It eventually progresses to nephrotic syndrome, characterized by sclerosis of the mesangium with the formation of Kimmel-Steele-Wilson nodules. Angiotensin-converting enzyme inhibitors slow the progression of hyperfiltration-induced damage. Systemic amyloidosis. The kidney is the most commonly involved organ in systemic amyloidosis. Amyloid deposits in the mesangium, resulting in nephrotic syndrome. It is characterized by apple-green birefringence under polarized light after staining with Congo red. Nephritic syndrome. Basic principles. Glomerular disorders are characterized by glomerular inflammation and bleeding. This results in limited proteinuria of less than 3.5 grams per day, oliguria and azotemia, salt retention with periorbital edema and hypertension, and red blood cell casts and dysmorphic red blood cells in the urine. Biopsy reveals hypercellular, inflamed glomeruli. Immune complex deposition activates complement. C5a attracts neutrophils, which mediate damage. POSTSTREPTOCOCCAL glomerulonephritis. This is a nephritic syndrome that arises after group A streptococcal infection of the skin, such as impetigo or the pharynx. It occurs with nephritogenic strains, which carry the M protein virulence factor and may occur after infection with non-streptococcal organisms as well. It presents 2 to 3 weeks after infection as hematuria with cola-colored urine, oliguria, hypertension, and periorbital edema. It is usually seen in children, but may occur in adults. Biopsy shows hypercellular, inflamed glomeruli on hematoxylin and eosin stain. It is mediated by immune complex deposition, showing granular immunofluorescence with subepithelial humps on electron microscopy. Treatment is supportive. Children rarely, about 1%, progress to renal failure. Some adults, about 25%, develop rapidly progressive glomerulonephritis. Rapidly progressive glomerulonephritis. This is a nephritic syndrome that progresses to renal failure in weeks to months. It is characterized by crescents in Bowman space of glomeruli on hematoxylin and eosin stain. Crescents are comprised of fibrin and macrophages. The clinical picture and immunofluorescence help resolve the etiology. A linear immunofluorescence pattern due to anti-basement membrane antibody is seen in Goodpasture syndrome, which involves an antibody against collagen in glomerular and alveolar basement membranes and presents as hematuria and hemoptysis. A granular immunofluorescence pattern due to immune complex deposition is seen in poststreptococcal glomerulonephritis or diffuse proliferative glomerulonephritis, which is the most common type of renal disease in systemic lupus erythematosus. A negative immunofluorescence pattern, or pauciimmune, is seen in Wegener granulomatosis, microscopic polyangiitis, and Churg-Strauss syndrome. Wegener granulomatosis is associated with cytoplasmic antineutrophil cytoplasmic antibody. Microscopic polyangiitis and Churg-Strauss are associated with paranuclear antineutrophil cytoplasmic antibody. Granulomatous inflammation, eosinophilia, and asthma distinguish Churg-Strauss from microscopic polyangiitis. IgA nephropathy. This involves IgA immune complex deposition in the mesangium of glomeruli and is the most common nephropathy worldwide. It presents during childhood as episodic gross or microscopic hematuria with red blood cell casts, usually following mucosal infections like gastroenteritis. IgA production is increased during infection. IgA immune complex deposition in the mesangium is seen on immunofluorescence. It may slowly progress to renal failure. Alport syndrome. This is an inherited defect in type 4 collagen, most commonly X-linked. It results in thinning and splitting of the glomerular basement membrane. It presents as isolated hematuria, sensory hearing loss, and ocular disturbances. Urinary tract infection. Basic principles. This is an infection of the urethra, bladder, or kidney. It most commonly arises due to an ascending infection and has an increased incidence in females. Risk factors include sexual intercourse, urinary stasis, and catheters. Cystitis. This is an infection of the bladder. It presents as dysuria, urinary frequency, urgency, and suprapubic pain. Systemic signs like fever are usually absent. Laboratory findings include urinalysis showing cloudy urine with greater than 10 white blood cells per high power field. A dipstick positive for leukocyte esterase due to pyuria and positive for nitrites because bacteria convert nitrates to nitrites, and a culture showing greater than 100,000 colony-forming units, which is the gold standard. Etiology includes Escherichia coli, which is the cause in 80% of cases. Staphylococcus saprophyticus, which has an increased incidence in young, sexually active women. Klebsiella pneumoniae, Proteus mirabilis, which is associated with alkaline urine with an ammonia scent, and Enterococcus faecalis. Sterile pyuria is the presence of pyuria, meaning greater than 10 white blood cells per high power field and positive leukocyte esterase, with a negative urine culture. This suggests urethritis due to chlamydia trachomatis or Neisseria gonorrhoeae. The dominant presenting sign of urethritis is dysuria. Pyelonephritis. This is an infection of the kidney. It is usually due to an ascending infection and has an increased risk with vesicoureteral reflux. It presents with fever, flank pain, white blood cell casts, and leukocytosis in addition to symptoms of cystitis. The most common pathogens are Escherichia coli, which causes 90% of cases, Klebsiella species, and Enterococcus faecalis. Chronic pyelonephritis. This involves interstitial fibrosis and atrophy of tubules due to multiple bouts of acute pyelonephritis. It is due to vesicoureteral reflux in children or obstruction, for example from benign prostatic hyperplasia or cervical carcinoma. It leads to cortical scarring with blunted calyces. Scarring at the upper and lower poles is characteristic of vesicoureteral reflux. Atrophic tubules containing eosinophilic proteinaceous material resemble thyroid follicles, a change called thyroidization of the kidney. Waxy casts may be seen in the urine. Nephrolithiasis. Basic principles. This involves the precipitation of a urinary solute as a stone. Risk factors include a high concentration of solute in the urinary filtrate and low urine volume. It presents as colicky pain with hematuria and unilateral flank tenderness. The stone is usually passed within hours, if not surgical intervention may be required. The most common type is calcium oxalate and/or calcium phosphate stones, usually seen in adults. The most common cause is idiopathic hypercalciuria, and treatment is hydrochlorothiazide. The second most common type is ammonium magnesium phosphate stones, most commonly caused by infection with urease-positive organisms like Proteus vulgaris. It classically results in staghorn calculi and renal calyces, and treatment involves surgical removal and eradication of the pathogen. The third most common stone is uric acid, which is radiolucent. Risk factors include gout and hyperuricemia, and treatment involves hydration and alkalinization of urine. A rare cause is cystine stones, most commonly seen in children and associated with cystinuria. They may form staghorn calculi, and treatment involve hydration and alkalinization of urine. Chronic renal failure. Basic principles. This is end-stage kidney failure. It may result from glomerular, tubular, inflammatory, or vascular insults. The most common causes are diabetes mellitus, hypertension, and glomerular disease. Clinical features include uremia, where increased nitrogenous waste products in the blood result in nausea, anorexia, pericarditis, platelet dysfunction, encephalopathy with hysterexis, and deposition of urea crystals in the skin. Other features are salt and water retention with resultant hypertension, hyperkalemia with metabolic acidosis, anemia due to decreased erythropoietin production, hypocalcemia due to decreased 1-alpha hydroxylation of vitamin D and hyperphosphatemia, and renal osteodystrophy due to secondary hyperparathyroidism, osteomalacia, and osteoporosis. Treatment involves dialysis or renal transplant. Cysts often develop within shrunken end-stage kidneys during dialysis, increasing the risk for renal cell carcinoma. Renal neoplasia. Angiomyolipoma. This is a hamartoma comprised of blood vessels, smooth muscle, and adipose tissue. It has an increased frequency in tuberous sclerosis. Renal cell carcinoma. This is a malignant epithelial tumor arising from kidney tubules. It presents with the classic triad of hematuria, palpable mass, and flank pain. All three symptoms rarely occur together, with hematuria being the most common. Fever, weight loss, or a paraneoplastic syndrome may also be present. It may rarely present with a left-sided varicocele because involvement of the left renal vein by carcinoma blocks drainage of the left spermatic vein. Gross exam reveals a yellow mass. Microscopically, the most common variant exhibits clear cytoplasm, the clear cell type. Pathogenesis involves loss of the VCHL tumor suppressor gene, which leads to increased insulin-like growth factor 1 and increased hypoxia-inducible factor transcription factor. Tumors may be hereditary or sporadic. Sporadic tumors classically arise in adult males as a single tumor in the upper pole of the kidney. The major risk factor is cigarette smoke. Hereditary tumors arise in younger adults and are often bilateral. Von Hippel-Lindau disease is an autosomal dominant disorder associated with inactivation of the VCHL gene, leading to an increased risk for hemangioblastoma of the cerebellum and renal cell carcinoma. Staging is based on the T stage for size and involvement of the renal vein, which occurs commonly and increases risk of hematogenous spread, and the N stage for spread to retroperitoneal lymph nodes. Wilms tumor. This is a malignant kidney tumor comprised of blastema, primitive glomeruli and tubules, and stromal cells. It is the most common malignant renal tumor in children, with an average age of 3 years. It presents as a large, unilateral flank mass with hematuria and hypertension due to renin secretion. It is associated with WTI mutation, especially in syndromic cases. WGR syndrome includes Wilms tumor, aniridia, genital abnormalities, and mental and motor retardation. Beckwith-Weidman syndrome includes Wilms tumor, neonatal hypoglycemia, muscular hemihypertrophy, and organomegaly. Lower urinary tract carcinoma. Urothelial carcinoma. This is a malignant tumor arising from the urothelial lining of the renal pelvis, ureter, bladder, or urethra. It is the most common type of lower urinary tract cancer and usually arises in the bladder. The major risk factor is cigarette smoke. Additional risk factors are naphthylamine, azo-dyes, and long-term cyclophosphamide or phenacetin use. It is generally seen in older adults and classically presents with painless hematuria. It arises via two distinct pathways. The flat pathway develops as a high-grade flat tumor and then invades. It is associated with early p53 mutations. The papillary pathway develops as a low-grade papillary tumor that progresses to a high-grade papillary tumor and then invades. It is not associated with early p53 mutations. Tumors are often multifocal and recur due to a field defect. Squamous cell carcinoma. This is a malignant proliferation of squamous cells, usually involving the bladder. It arises in a background of squamous metaplasia, as the normal bladder surface is not lined by squamous epithelium. Risk factors include chronic cystitis, schistosoma hematobium infection, and long-standing nephrolithiasis. Adenocarcinoma. This is a malignant proliferation of glands, usually involving the bladder. It arises from a urachal remnant, where the tumor develops at the dome of the bladder, from cystitis glandularis, or from extrophy, which is a congenital failure to form the caudal portion of the anterior abdominal and bladder walls.